Hello, welcome back to the Dementia Awareness course. This is part 2. This is just a quick reminder of the training notice. So remember to break it up. Don't be a passive participant. So try and undertake all the activities within the training course. Take notes, repeat if you need to, and remember you can complete this individually or as a group. But remember to complete your workbooks individually. And finally, do ask if you're unsure about anything. The learning outcomes for part 2 are as follows. By the end of this session, participants will be able to understand the key features of the main theoretical models relating to dementia. You'll also appreciate the factors relating to an individual's experience of dementia. And finally, you'll know how to apply a person-centred approach to care. Models of dementia. Within health and social care, a dementia model provides a framework in which to understand the health and social care needs of the person, developing ideas for care and support, and putting them into practice. Within this section, we will explore 3 important models of dementia. These are the medical model, the social model, and the biopsychosocial model. So firstly, we have the medical model of dementia. The medical model views dementia as a clinical syndrome, which is characterised by the cognitive impairment itself, about which nothing can be done. So it focuses on the disease and places importance on treating the disease rather than the person. And also it focuses on the impairment as a problem. The model tends to create dependency, restrict choice, disempower, devalue, and reinforces stereotypes. The social model of dementia. Unlike the medical model of dementia, which focuses on the disease, the social model of dementia focuses on the person's unique experience of dementia. Therefore, it focuses on the person's emotions and behaviour. It places the person within the context of his or her own social circumstances and biography. It also provides support which is individually tailored to meet the person's needs. And it also seeks to ensure that the person's skills, capabilities and achievements are retained. By learning about each person with dementia as an individual, within his or her own history and background, care and support can be designed to be more appropriate to the individual. The biopsychosocial model. To effectively care for people with dementia, it's important to take into account their background, personality, and mental and physical health, in addition to their social and psychological needs. The biopsychosocial model focuses both the disease process and the person simultaneously. So it focuses on the importance of medical treatments to improve symptomology of dementia, whilst also considering the personality, history and social context of the person. Support is also individually tailored to meet their needs, with the aim of retaining skills and abilities. So it's basically a combination of both the medical model and the social model of dementia. Think about how you would feel if you developed dementia and the people who were supporting you demonstrated no respect for you as a person and they just focused on the dementia and the disease process itself. Pause the video now and jot down some thoughts and meet me on the next slide. So as you can see from this infographic, it's important to consider all 3 aspects when caring for someone with dementia or people with any condition or disability. So the bio stands for the pathology, the disease, the symptoms, treatments and tests. The psycho aspect is about how you feel and the psychological aspect. And social are the hobbies, family, isolation, money, everything else surrounding the person. And it's very useful to remember the phrase, the medical support keeps me alive or manages symptoms. but it is the psychological and social support that enables me to live. Often when we think of a disability, we think about a person who is physically disabled. For example, we might think about a person who's unable to walk. However, if we look at the Equality Act 2010, it states that a person is disabled if they have a physical or mental impairment. The impairment has a substantial and long-term adverse effect on their ability to perform normal day-to-day activities. So based on this definition, do you think a person with dementia has a disability? And the answer is yes. So under the Equality Act, a person who is living with dementia is recognised as having a disability. It's important to see dementia as a form of disability because of the way it affects different areas of the body and affects many areas of functioning, as we've seen earlier in the presentation. Viewing dementia as a form of disability challenges the way care workers adapt their care approach to meet the person's needs, therefore not expecting the person to change. As with any disability, care workers can work with and around the difficulties and compensate for them in other areas, thus preventing further disability. The impact of age on the experience of dementia. Most people think of dementia as something that happens to only older people. However, there is a proportion of people diagnosed with dementia at earlier ages. This dementia is often referred to as early onset dementia or young onset dementia. And these are usually people between the ages of 30 and 65 years old. There are 42,000 younger people who have been diagnosed with dementia in the UK. There's very little public and professional awareness of early onset dementia, and this can make it very difficult for younger people to access appropriate support. The lack of awareness and understanding can make getting a diagnosis difficult, and healthcare professionals often misdiagnose early onset dementia as depression. Being diagnosed with dementia can be devastating at any age, but particularly so for people who are diagnosed at a younger age. Although the symptoms of dementia are similar whatever a person's age, younger people with dementia may have different needs. They're also more likely to have dependent children and be in work at the time of diagnosis. They may also have financial commitments such as a mortgage. They'll also find it more difficult to rationalise losing skills at such a young age and find it more difficult to access appropriate information and support. All these factors influence the experience of living with dementia, and this means services need to work hard to be accessible and appropriate for the younger person and their family. The impact of a learning disability on the experience of dementia. People who have learning disabilities have an increased risk of developing dementia as they age than others. They also tend to develop dementia at a younger age. Down syndrome is the most common cause of learning disabilities, and people with Down syndrome are at a particular risk of dementia. Dementia generally affects people with learning disabilities in similar ways to people without a learning disability. However, there's a chance that the early stages may be missed because the individual concerned may have difficulties communicating how their ability has changed. Also, the dementia will compound the learning disability and other associated disabilities such as reduced eyesight and hearing. However, one thing to bear in mind is any change in somebody's abilities needs to be looked into, and that goes with people with learning disabilities as well. Individual experiences of dementia. Although people who are living with dementia may exhibit similar signs and symptoms, it is essential to realise that every person's experience of dementia will be unique to them. Although dementia happens as a result of a neurological impairment, every person's experience will be shaped by a variety of individual factors, including personality, past experience, their current state of health, and the degree to which the individual's been affected by the neurological impairment. In order to support people who have dementia, we need to understand how their dementia affects them as individuals. You may have heard of Tom Kitwood, Professor of Psychogerontology at Bradford University. He wrote a groundbreaking book in 1997 entitled Dementia Reconsidered. In this book, he put forward his enriched model, where the aim was to enrich the lives of people with dementia by changing the way people viewed people with dementia and how they delivered care. The enriched model is based on the biopsychosocial model that we discussed earlier. So according to Kitwood, a person's experience of dementia is made up of 5 different aspects. Firstly, there is the neurological impairment. So this is the type of dementia and how it impacts on function. This is what we discussed in part 1. Then he goes on to describe personality and life history. So Kitwood said the key way that we make sense of the here and now is through reference to our past experience. This doesn't change for anybody with dementia. It's important to learn about their past relationships, occupations, hobbies and experiences for 2 main reasons. 1, it builds our respect for them, enhancing their personhood, and also it gives us an idea of how they might perceive or interpret a current situation. Talk to the person, talk to their family. Use the This Is Me or life history document to try and find out about the person under your care. Next, there is the person's state of health and physical well-being. A person with dementia may have other illnesses, whether temporary or long-standing, which will impact on their functional ability and how they are experiencing their time in our care. These may include pain, sensory impairments, chest infections, UTIs, wounds, trauma, heart conditions, and mental state. It's so important to understand whether the person you're caring for has more than just the diagnosis of dementia. How else would you be able to understand how they are feeling? Finally, there's social psychology. People and their experiences are moulded by their sense of self, relationships, social interactions and the environment. Our relationships and interactions with people we are caring for have the potential to be extremely positive or extremely damaging. Considering this whole picture and knowing the person will make all the difference to our relationships and the way we interact with a person with dementia, and enhancing their well-being and health. The impact of attitudes and behaviours of others on the experience of dementia. In the past, dementia was perceived as a condition with low priority and was greatly misunderstood by society. Traditionally, attitudes towards dementia were defeatist and negative, with assumptions that nothing could be done for the person. This attitude, however, has changed, and we have worked towards achieving a person-centred approach to dementia care. This changing culture of care is actively encouraged, with a focus on the person's strengths and individuality, rather than their deficits. Kitwood studied the traditional approach to dementia care and was very critical of what he found. His findings highlighted harmful attitudes and actions towards people who had dementia within health and social care establishments. Kitwood termed this malignant social psychology, and this can occur even when staff believe they are being kind and caring. Kitwood identified 17 elements of malignant social psychology. The first he highlighted was treachery, and this was where caregivers use deception to distract or manipulate and therefore force a person into compliance. Now this was not for the well-being of the person, but for the convenience of the caregiver. Disempowerment, so not allowing somebody to use their abilities or failing to support that person complete an action once initiated. And this was primarily because it was easier for the caregiver just to do it for the person. Infantilization, patronising a person in the way an insensitive parent may treat a young child. They're still adults, so they need to be treated so. Labelling, using the categories such as dementia as the main basis for interacting with and explaining the person's behaviour, not seeing the person as an individual. Stigmatisation, treating the person as a diseased object, alien or outcast, and not a human being. Outpacing, providing information or presenting choices too quickly for a person to understand or complete. So that wasn't providing information in an individualised way. Invalidation, not acknowledging a person's experience or feelings. Banishment, sending a person away or excluding her or him physically or psychologically. Objectification, treating a person like a lump of matter to be pushed, lifted, filled, pumped or drained rather than a sentient being, particularly during washing and dressing. Ignoring, carrying on a conversation or action as if the person was not there. Talking over the person, not including them within the conversation. Imposition, forcing a person to do something, overriding their desire or denying him or her any choice. Intimidation, using power threats that cause anxiety and fear, such as if you don't do this, then this will happen. Withholding, refusing to give somebody something requested, for example, attention, or to meet evident needs. Accusation, blaming a person for actions or failure of action that arise from lack of ability or understanding. Disruption, intruding suddenly or disturbingly a person's action or reflection, crudely breaking her or his frame of reference. Mockery, making fun of strange actions or remarks, teasing, humiliating, or making jokes at a person's expense. And disparagement, telling a person she or he is incompetent, useless, or worthless, giving him or her messages that damage their self-esteem. So next we have an activity, and what I'd like you to do is to look at the 17 attitudes and behaviours that we've just discussed and write down how you would feel if someone you were dependent upon and who was caring for you behaved in this way towards you. You'll find this table in resource 7, so please pause the PowerPoint now and meet me on the next slide. So how did that feel? It's clear to see that these negative attitudes can only serve to further disable people and promote ill-being. In contrast to malignant social psychology, person-centred care aims to break down the barriers and negative attitudes that sometimes exist within health and social care. It encourages staff to work in a way which encourages the acceptance and respect of a person regardless of their condition. This is referred to as unconditional positive regard, which is a concept developed by the humanistic psychologist Carl Rogers. Essentially, it's the acceptance and support of a person regardless of what the person says or does. Person-centred care meets the person's whole needs, not just their physical needs. Key elements in person-centred approach include placing the person and not their dementia at the centre of their care, valuing and respecting the individual, giving consideration to the person's perspective, and considering needs and emotions of each individual as the focus point, These positive attitudes are empowering, enabling, and can help people with dementia feel good about themselves. Kitwood's psychosocial needs. Kitwood's work focused on the psychosocial needs of people, and he highlighted 6 needs which are particularly important to those living with dementia. These needs are closely interconnected and all revolve around the central need of love in the middle. Kitwood believes that these needs require nurturing in order for the person to thrive, and because they are interconnected, if one need is not met, it will feed negatively into the other needs. What do these words mean to you? Pause the video now and note down your thoughts. When you've finished, please unpause the video to continue. Love. Health and social care workers can support the need to be loved by demonstrating unconditional positive regard, without any expectation or direct reward, or withdrawing a psychological need if someone does or says something a carer doesn't like. Comfort. Feeling comfort is our need to be warm, dry and clean, having a full stomach and not feeling thirsty. Comfort might also mean to have quiet when we need to be free of pain and to have the freedom to move, and to have a sense of closeness and being able to bond with others. Identity. We all have the need for personal identity, from the clothes we choose to wear and the food we prefer, and the way we like to have our hair. These are all identifying factors that help us and others to identify with who we are. Occupation. Most of us want to be occupied with something, to feel like we have worth and purpose in life. From being involved in daily activities to engaging in a planned activity programme, it's important that the person's able to occupy themselves with meaningful things. Inclusion. Inclusion means that we want to be part of something. If we feel left out, it can make us feel bad. People living with dementia may lose track of conversations easily. Being mindful of their feelings and inclusion is important. Finally, there's attachment. Our connections in life are also crucial to our feelings of well-being. Everyone wants to feel connected to something or someone, and often a combination of both. We also have a need to form wider attachments in our communities or in the groups. So how can we meet these 6 psychosocial needs? With regards to love, we can demonstrate unconditional positive regard by accepting the person for who they are. We can ensure that the person is comfortable by ensuring that they're warm, dry, clean, they have a full stomach, not feeling thirsty, and have access to quiet time if they need to. Also giving them the freedom of movement to walk around as they want, and to be free of pain, so always be mindful of whether somebody's in pain or not. Fostering inclusion by including the person in what's happening, by enabling the person to be involved both physically and psychologically. Supporting and encouraging the person to engage in meaningful activities at whatever level the person is able and comfortable to do. Maintain their identity by using their preferred name, provide a choice of clothing, and give them their preferred food. Also have their hair styled the way they'd like it, or how they used to have it. Attachment. It's important to foster new or maintain existing relationships and to validate their reality. So now we have a case study. Mr. Vazdev is a 74-year-old man diagnosed with Alzheimer's disease. He fell and broke his hip and has been admitted to a specialised unit for reablement. He works as a milkman for over 40 years and gets up at 5 a.m. every morning. Within the reablement unit, the unit routine is that the lights are not switched on until 7 a.m. Mr. Vazdev wakes up at 5 a.m. the following morning, rings his care bell and asks the support worker for a cup of tea. The support worker who answers Mr. Vazdev's call bell tells him that it's too early for a cup of tea and that he should go back to sleep. So if you look in resource 8, I would like you to complete the questions and then meet me on the next slide. So if you pause the presentation now, I'll see you soon. Case study feedback. So what do you think about the case study of Mr. Vazdev? Now, did the caregiver provide a person-centred approach? Well, he didn't. He adopted a service level approach. So instead of tailoring the service towards the individual needs, he adopted a one-for-all service-led approach. So what did he do wrong? Well, he didn't view Mr. Vazdev as an individual, and he didn't consider his life history, nor his usual daily routine. So what should he have done? Well, he could have read the case notes or his case history and demonstrated some awareness of his life history, that is, that he was a milkman. He could have supported his daily routine with this and provided a cup of tea. Or he could have took an opportunity for reablement, maybe walk into the kitchen area. He could have got to know how Mr. Vazdev likes his tea. He could have seen what his preferences were. He also could have taken this opportunity to develop a relationship whilst nobody else was around. He could have had a chat with Mr. Vazdev about his life history and how he was feeling. The benefits of working in a person-centred way. So what do you think are the benefits for the individual, that is the person with dementia, the staff member and the organisation as a whole? Jot down some ideas now and pause the presentation and meet me on the next slide. There are many benefits of working in a person-centred way. Firstly, for the individual, it gives them a sense of autonomy, that's independence, choice, trust and respect. They're recognised and valued as an individual. The person can retain their abilities. They're given a sense of purpose in life, and their well-being can be enhanced. It gives them a positive experience, can boost their self-esteem and can reduce their anxiety. For staff, it promotes knowledge of the person, creates stronger partnerships between the individual and the staff member. The staff can feel highly valued and they can find it easier to meet the needs of the person if they know them well, and therefore it can also mean practice is more efficient. And for the organisations, quality outcomes will increase. They will get more referrals due to the reputation, and they're more likely to have a higher staff retention rate as well because of the job satisfaction. Finally, I'd like to give you an inside view of what it's like to experience dementia. This is a video entitled Dementia from the Inside, and you'll find this in Resource 1, slide 24. Whilst you watch the video, have a think about what you've learnt during the course, particularly in relation to how is the dementia affecting the function of the person's brain? How would you feel if you were experiencing the world in this way? And how would you like someone to treat you if you were feeling like this? If you pause the video now, and I'll meet you on the next slide. Okay, so we've come to the end of the course. I hope you've enjoyed it. Please do look out for other courses pertaining to dementia in the future, as this is basically a springboard onto other modules. In particular, there is dementia and reablement, responding effectively to the changing behaviours of people with dementia, engaging people with dementia in meaningful and purposeful activities, learning disability in dementia, that's actually available now, and the role of medication in dementia. With regards to returning your workbooks, please complete your workbook electronically and send it to me at jo.virgo@eastsussex.gov.uk, and please send it by 5 p.m. on Friday. Thank you for viewing the course and participating in the course. Thank you very much.